you so much, Richard. So good afternoon and welcome to this meeting of the Health and Government Operations Committee. Please bear with us if we encounter any technological issues. This meeting is being streamed on the Maryland General Assembly YouTube channel. Committee members will be muted during the hearings. Following the presentation of the witnesses and the bill, you can raise your hand. If you have a question, I will call on the delegates to ask questions. When it's your turn, please wait a moment while staff unmutes your screen. Keep in mind that we are in a Zoom meeting and we will have to adhere to our usual committee rules. We're going to have witnesses, the bill sponsor, and again, thank you for your patience. It's allotted 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes in support. Please stay in the hearing until the delegates have had an opportunity to ask questions. Next, 5 witnesses will each be allowed to speak for 2 minutes in opposition and then respond to questions. Please conclude your remarks when you see the timer finish. That is really important. Members must remain present with your video camera on during the entirety of the hearing. Are there any questions? If not, this is the order of the bill hearings for today. We have 4 bill hearings. One has been removed, which is House Bill 14, is no longer on the agenda. But we do have House Bill 32, which will be the first bill. Delegate Bagnall, House Bill 48, Delegate Bill Castro, and House Bill 96, Delegate Shetty, and then the last bill of the day, House Bill 129, Delegate Charkoudian. Thank you so much again. House Bill 32, Delegate Bagnall, will you be so kind and give us your testimony, please?
Thank you very much. Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. For the record, I'm Delegate Heather Bagnall, District 33, Anne Arundel County, here on behalf of HB 32, Mental Health Law, Petitions for Emergency Evaluation Electronic Record. House Bill 32 is a small but significant modernization bill which authorizes the electronic transmission of approved petitions for emergency evaluation. We have discussed at length in this committee the issue of ER wait times and constituents in crisis deteriorating while waiting for assessment and care in the correct venue. Currently, if an emergency petition is granted, a peace officer must present the original physical document at time of transfer, essentially expanding the time required to get an evaluee to care, as well as requiring extended time a peace officer is in transit, especially if the document has to cross jurisdictions. By allowing these positions to be more easily shared, it expedites and optimizes the transfers, therefore enabling a faster response to a request for an emergency evaluation. It is imperative that we respond to these emergency situations as quickly as possible to more efficiently provide care for the evaluee. Additionally, this will alleviate the requirement of a peace officer having a paper copy or original copy of the petition, which again allows for easier transmission through the court system. You will see in the written testimony that the health providers, hospitals, judiciary, law enforcement, and insurers all support this bill. Now, to be clear, HB 32 does not alter the standards or process for filing an emergency petition, nor how it is granted. The bill does not change any current restrictions surrounding electronically filing through Maryland court, and it does not allow for a petitioner to file a petition for emergency evaluation electronically. It simply allows for the transmission of an endorsed petition to be done electronically. And I have submitted a small technical amendment to ensure the bill is not interpreted to permit the electronic filing of an emergency evaluation petition. HB 32 provides us an opportunity to modernize our system, utilize technology, and provide more immediate care to our constituents in crisis. I therefore respectfully request a favorable report on House Bill 32 and cede my remaining time to my panel.
Thank you, Delegate Bagnall. So we have our first panelist is Ms. Evelyn Burton. Ms. Burton, good afternoon. You have 2 minutes to present. Will you get started, please?
Certainly. Good afternoon, Vice Chair Tina Melnick and members of the committee. Good to see you again. For the record, I'm Evelyn Burton. I am the Maryland Advocacy Chair for Schizophrenia and Psychosis Action Alliance. And you have my written testimony, but I wanted to point out that with some psychotic illnesses like schizophrenia and bipolar disorder, there is a neurological deficit which prevents recognition that they are ill and need treatment. And research cited in my testimony shows that prompt treatment is absolutely vital for preventing brain damage from psychosis and increases the prognosis for recovery. Electronic submission enables the petitioner to speed things up, and it's important in this age where telemedicine, you often have the provider and the patient in different locations. And I'm hoping that this bill would help in the situation that a family brought to me a few weeks ago, where their son with schizophrenia was living in Frederick County and under the services of the ACT team there. And he became homeless and ended up in Anne Arundel County. And the ACT team seemed at a loss to be able to petition him. And so the family, they had to go to the court to do the petition, but the court was closed until Monday. So he was out on the street, unable to find food or shelter for the 2 days that the family had to wait to go to the court. So anything this bill does to increase the time that is needed to wait to get these petitions filed would be very helpful and could save lives. So we request a favorable report. Thank you.
Our pleasure. Thank you for your testimony. We appreciate it. Next, we have Ms. Cyphers.
Thank you, Madam Vice Chair, and good afternoon to the members of the Health and Government Operations Committee. I'm Maura Cyphers with Compass Government Relations here on behalf of the National Alliance on Mental Illness Maryland. NAMI Maryland and their 11 county affiliates represent a statewide network, more than 45,000 families, individuals, and community-based organizations and service providers. NAMI Maryland is here in strong support of House Bill 32. When a mental illness is present within a family, I think for most folks, the potential for crisis is never far from mind. And as unpredictability is sort of the nature of mental illness, no matter how well it's treated, crisis episodes can be incredibly overwhelming, especially because the need to immediate access for healthcare services is vital. And so emergency petitions for involuntary hospitalization can help people get that urgently needed treatment. Delegate Bagnall did an excellent job sort of running through the process. Emergency petitions, or EPs, they are highly process oriented. I think we included a flow chart describing the process. And what we're here today in favor of and to talk about is a very simple change to modernize one step. So up until now, the reliance or requirement for a physically signed document has led to some confusion and on occasion significant admission delays. So I think this is the year 2022, so we can bring the EP process into this century, permit the use of digital signatures, know that the hospitals and the courts are both here in agreement with this change and believe that they have the tech to ensure this security. So I think even a small measure of greater certainty is really a blessing for people experiencing a mental health crisis and their family members. And so I think like any other health crisis, we want to make sure that we're addressing a mental health emergency quickly and effectively. And for these reasons, NAMI Maryland asks for your favorable report. Thank you.
Thank you very much for your testimony, Ms. Cyphers. That was the favorable panel. Now we have only one person unfavorable, Mr. Vince McCoy. I do not see you actually in the participants, but I will call your name, Mr. McCoy. He's not present. Actually, that concludes the testimony on House Bill 32. And just for the members, I would like to thank on behalf of the committee, Delegate Bagnall. This is the first time that I see the Department of Health. There's a favorable written letter, the carriers as well, the Maryland Psychological Association, MECI. Great job. Thank you so much. Next, we have House Bill 48, Delegate Bel Castro. Good afternoon. And the bill is titled Public Health, Maryland Suicide Fatality Review Committee. Will you get started with your testimony?
Thank you, Chair
Our
Pendergrass,
pleasure.
Vice Chair Pena-Melnick, members of the Health and Government Operations Committee. I appreciate the opportunity to present House Bill 48, Public Health, Maryland Suicide Fatality Review Committee. Between the years of 2000 and 2018, the number of recorded suicide deaths in Maryland increased from 474 to 650, and this represents a 37% increase. Across all ages, 1/2 of all persons who die by suicide in the state have experienced issues with mental health. It is widely known that suicide is a serious public health problem, but it's a preventable problem. Currently, suicide deaths are significantly underestimated and inadequately documented, preventing efforts to identify and reduce such deaths. If we are going to stop the upward climb in the rate of suicides in Maryland, simply put, we need data. And HB 48 seeks to provide just that. So under this bill, the Maryland Suicide Fatality Review Committee would have the authority to study deaths by suicide in much greater detail than the state is currently able. And this is accomplished by allowing the team access to important information related to specific incidents of suicide. And through the data collected by the team, they would be able to identify trends, risk factors, opportunities for intervention, lapses in response, and strategies for the prevention of suicide deaths. And for an example of actions that could come from a committee such as this, we can look to Washington County, Oregon, where they established a similar committee that studied the escalating rate of suicides in their jurisdiction. And through their analysis, they were able to identify that in the days and weeks prior to a suicide, individuals would turn their pets over to an animal shelter. And so by identifying a trend such as this, they were able to find opportunities for intervention and train staff at the shelter on how to identify and respond to folks in crisis and direct them to help. And since implementing a suicide fatality review committee, Washington County, Oregon has seen the rates of suicide decrease in a time when the rest of the country has seen increases. I want to mention that this bill passed the Senate unanimously last year. And additionally, this was a barrier to movement in the House. We worked really hard to significantly decrease the fiscal impact of the bill this year. We acknowledge that there are some startup costs associated with this bill, and those are mainly associated with enhancements to CRISP, where the information collected under this bill would be housed. We have a wonderful panel here today, and I look forward to them sharing with you why it's so important that we move forward with this initiative. But I just want to thank you for the opportunity to present House Bill 48, and I respectfully ask for your favorable report.
Thank you very much, Delegate, for your testimony. Your first panelist is Ms. Janelle Cubbage, and forgive me if I did not pronounce your name correctly. Good afternoon.
You did a great job.
Okay, thank you. You can get started.
Good afternoon, Chairman Pendergrass, Madam Vice Chair, and members of the committee. My name is Janelle Cubbage, and until August of 2021, I served as Director of Suicide Prevention at the Maryland Department of Health and chaired the State Suicide Prevention Commission. One of the biggest challenges was not having the qualitative data needed for tailored prevention. We had access to the how many and the how much, but not the what and the how and the why. Without fatality review, we wouldn't have valuable insights like knowing fewer than 5% of suicide decedents have their cell phones with them at their time of death, which has major implications for messaging and prevention strategies at sites like bridges and railways. If I ask how much is a life, the Centers for Disease Control would tell us that on average, one suicide death costs the state of Maryland about $1 million. But that $1 million pales in comparison to the 657 Marylanders who died by suicide in 2019. The at least 82,125 people impacted by those suicide losses, and the 12,812 years of potential life lost. The fiscal note estimates the cost for the review team at $319,000 per year. If we save just one life, the cost of the suicide fatality review team will have more than paid for itself. I respectfully ask for your favorable report for HB 48, and thank you for the opportunity to speak.
Thank you for being with us today. Now we have Ms. Holly Wilcox. Will you be so kind and get started?
Sure. Good afternoon. Thank you, Chairman Pendergrass, Madam Vice Chair, and members of the Health and Government Operations Committee. My name is Holly Wilcox. I'm a professor at Johns Hopkins University. I have been focused on work at the intersection of public health and suicide prevention for over 30 years. I also serve as the co-chair of the Maryland Commission on Suicide Prevention, and I'm president-elect of the International Academy of Suicide Research. I support House Bill 48 because suicide fatality review is a public health best practice that will allow us to translate data into action in almost real time to save lives. Multidisciplinary review will provide the types of nuanced data we need to advance suicide prevention in Maryland. At this phase of the pandemic, we are witnessing a national crisis in youth mental health, as well as major health inequities. We need to know how best to prioritize the limited resources we have and what partnerships, policies, and programs are essential to prevent suicide statewide. I urge you to vote in favor of House Bill 48. Thank you very much for the opportunity to speak.
Thank you for being with us today. Next, we have Mr. Paul Nestak.
Hi, I don't know if you can see me because I'm having some video problems.
We can see you and we can hear you, and good afternoon.
Great. Thank you. Thanks for having me here today.
Our
So
pleasure.
as you mentioned, I'm Paul Nestat. I'm a psychiatrist and a suicide researcher at Johns Hopkins, but I'm actually here representing myself. These are not the views of Johns Hopkins. I do serve on the Baltimore City Council President's Suicide Prevention Work Group, the Executive Board of the Maryland Psychiatric Society, and I consult for the Opioid Fatality Review Committee and the Governor's Commission on Suicide Prevention. I'm here in support of HB 48 for the creation of a Suicide Fatality Review Committee. So as you've been hearing today, suicide is a prominent and escalating cause of death in Maryland. Nationwide, suicide is the 10th leading cause of death and the second leading cause of death in Americans under 40. In Maryland, the suicide rate has climbed by 18% over the past 5 years. We're still waiting to measure the full mental health impact left by the pandemic, so we might see more of an increase. Early data on pandemic level suicides, which I published myself last year, showed the pandemic's impact on suicide was felt disproportionately by Black Marylanders, whose suicide rates almost doubled during the initial COVID lockdowns of 2020. When that data on Maryland's pandemic suicides first came out, I found myself talking to policymakers, speaking to the press about the best way to interpret these deaths. I was asked about how the pandemic might specifically contribute to suicide deaths. They might be related to grief or fear of illness, job loss, isolation, et cetera. But I could only really guess about how the pandemic might or might not have led to that suicide increase, which is not really helpful if the mission is to prevent further suicides. Maybe these deaths were totally unrelated to the pandemic or the mitigation measures, we just don't know. The traditionally most high-risk group for suicide, older white men, continue to demonstrate escalating suicide rates, but there's new vulnerable subpopulations dying at higher rates. And frankly, we don't know what drives any of these groups to suicide, but do know the problem is worsening. The proposed Suicide Fatality Review Committee would have the authority to fully investigate these deaths in much greater detail than the state's able to. The team will be able to characterize the final pathways to suicide and interpret these for proximal risk factors, missed points of interventions, and patterns of vulnerability, producing reports and recommendations for future suicide prevention efforts. Any effort to prevent suicide must be informed by data, to target interventions and monitor their successes. And the Suicide Fatality Review Committee is the best way to accomplish these goals and save lives. So I urge you to vote in favor of the creation of this committee.
Thank you so much for your time today. We appreciate it. Next, we have Mr. Michael McLaughlin.
Can you hear me?
Yes, we can hear you. Good afternoon.
Can you see me?
Yes, we can see you clearly. Thank you for
Okay.
being with us.
Thanks, Vice Chair Peña-Melnick and members of the committee, and especially thank you, Delegate Bel Castro, for bringing this bill forward again. My name is Michael McLaughlin. I live in Laurel with my wife and adult daughter. In April of 2018, we lost our son, Kevin, to suicide. I'm here to speak for Kevin and the rest of my family and other families who have been affected by the scourge of suicide, and urge you to vote in favor of House Bill 48 that will create the Suicide Fatality Review Committee. You have my written testimony detailing the difficulty I had obtaining information related to Kevin's death, so I'll just briefly summarize. My hope is that a Suicide Fatality Review Committee will save lives by helping identify individuals at risk of self-harm and by spotlighting the risk we all accept when we take, even as prescribed, medications that are known to cause suicidal thoughts and behaviors. A suicidal fatality review committee will also help start a conversation that so many people are reluctant to have, because suicide is a subject shrouded in stigma and lack of information, as well as a veil of tears. If this bill had been brought forward a couple of years ago, I don't know if I would have been able to do this. Even if you have not personally been affected by the loss of a friend or loved one to suicide, it is difficult to consider that it can happen to any of us or anyone we know and love. So thank you for having the courage to begin this difficult conversation by moving House Bill 48 forward. The Suicide Fatality Review Committee will provide information that is long overdue, the information that will be invaluable to the researchers on this panel and will ultimately save lives. Thank you.
And thank you. I know Michael personally. He's my constituent. I'm so sorry again for your loss, and thank you for being with us today. Okay.
Thank you.
Our pleasure. Next, we have Ms. Eileen Zeller.
Hi, thank you so much for having me this afternoon. My name is Eileen Zeller, and I retired from the federal government's Substance Abuse and Mental Health Services Administration, SAMHSA, in 2017. I was lead public health advisor in the suicide prevention branch. I now chair the Governor's Commission on Suicide Prevention, and I have to say that we were happy to recently welcome Delegate Cullison as one of our new commissioners. The commission is charged with developing a state plan, making recommendations to prevent suicide. But our effectiveness, as you've already heard, is really handicapped because we do not have the data and information we need. We currently base our work on valuable but really broad data, numbers and rates of Marylanders who died by suicide broken down by demographics, jurisdiction, the methods they use. We get some more context from the Maryland Violent Death Reporting System, like toxicology reports and law enforcement reports. Maryland does have child and overdose fatality review teams, but together they review fewer than 15% of the state's suicides because youth represent 3% of state suicides and overdoses about 12%. So in 2019, we had minimal qualitative data for 558 Marylanders who died by suicide. So here are some examples of information we don't have. Who did the person have contact with in the days and hours before their death? Which systems did they touch? Were they seen in an emergency room or by a primary care doc? Did they see an attorney? Were they active in a faith community? How did they use social media? We need these kinds of details to get a more complete picture, to look for points where we could have intervened and trends that allow us to tailor our recommendations and plan to be responsive to the needs of Marylanders. Here's just one example. I also picked one from Oregon of how a state used this kind of data to prevent suicides. So Oregon identified eviction as a major risk factor. Law enforcement began adding crisis line information to eviction paperwork. And in one county, the mental health crisis response team was sent to each eviction. Within 2 years, they reduced eviction-related suicides from 30 to 1. That's the kind of intervention we could implement with the kind of data that would be collected and analyzed by the Suicide Fatality Review Committee. So on behalf of the Governor's Commission on Suicide Prevention, I urge a favorable report on House Bill 48. Thank you.
Thank you for your service. We really appreciate it. Next, we have an unfavorable, which is Mr. Vince McBoy. Did he make it, Richard?
No, ma'am.
Thank you so much, Richard. Are there any questions? I see Delegate Collison, followed by Delegate Landis. Delegate Collison.
Thank you very much, Madam Chair. This is a question for the sponsor. And I have looked through the testimonies, the written testimonies that we have. And I did not see the behavioral health or the Department of Health. So I'm wondering if you'd had any contact with them, if they had given you any indication of their perspective on the legislation. Just trying to see where they are.
I'm muted. I still haven't figured it out yet. I appreciate the question. It's a really good question. And I will say this year we have not had those discussions. In previous years we have been in discussions with the Department of Health, but not recently.
And in your previous discussions, what was their sentiments?
So for that, Janelle, you might be the best person to defer that question to. Do you believe that you can answer that one better?
I can try.
Okay.
I think that there is support for establishing a fatality review process. As you know, the Department of Health already does so with child fatality review, as well as local overdose fatality review. At the time of my departure, we were in the process of expanding my team in the suicide prevention office to build capacity to do more work around data collection and suicide surveillance. As the former chair of the Commission on Suicide Prevention, I was in support personally of this legislation, but obviously I cannot speak on behalf of the Department of Health.
Thank you very much. Thank you, Delegate, for this bill.
Thank you.
And if I may add, great question, Delegate Collison. Delegate Belcastro, will you be so kind and get in touch with the Department of Health and
You bet.
Behavioral Health? Thank you
Right
so
away.
much. We have now Delegate Landis, followed by Chairman Pendergrass. Delegate Landis, you may ask your question.
Thank you so much,
Our
Vice
pleasure.
Chair Pena-Melnick. And thank you, Delegate Castro, for bringing this legislation forward. I've had personal experience with suicide, a very, very, very close friend of mine. And after the fact, I thought back about what was he going through in his life. And I realized too late that there were telltale signs that I did not pick up prior to him committing suicide. So this legislation is extremely important to establish the Maryland Suicide Fatality Review Committee. My question would be that, you know, granted the legislation is passed and the review committee is established, the research is done by the medical examiner. They know they've identified the causes of what can cause the telltale signs. How will Marylanders be informed? How will Marylanders be educated about the telltale signs? And that's my question.
Yeah, that's a really great question. And for that, I'm going to hand it over to Mr. Nestat. He's expert in this field, and I think we'll be able to give you a very comprehensive answer.
Thank you.
Mm-hmm.
Thank you, Delegate. I think that the most important way that it'll be conveyed is through reports. So there's an annual report mandated in this bill where it would be presented to the governor. If there are particularly salient points that should go out to the public, it might make a lot of sense for the committee to help facilitate announcements, through the Department of Health, where information can be spread through local partners and maybe even directly to the population about specific risk factors, as we've seen happen in Oregon. But the primary way that information would be conveyed would be through the annual reports. I think very similar to how it's done for the child fatality review teams and the opiate fatality review teams.
Okay, thank you so much.
Thank you. Chairman Pendergrass.
Thank you, Madam Chair. I'm looking at the fiscal note, and the fiscal note is substantial, which is not to say that balancing it against people's lives makes that a same computation. Nonetheless, when you talk, Delegate Belcastro, to the department, I'm wondering why it costs $300,000 a year to review approximately 650 suicide deaths. I'm not sure where that comes from, and I think we need to understand that. And if there's anybody in the panel who would like to speak to what that might be about, if somebody knows, that would be fine. Otherwise, it will go to subcommittee and be discussed there. Thank you. And I'm not asking the question of a delegate because, of course, we don't ask questions of delegates. Oh, well, I guess the sponsor can answer it if she wants to, but I'm not. I'm actually hoping there is somebody there from the health department watching this.
So I can take a stab at it. Last year when we presented this bill, it was over $500,000 was the fiscal note. We've worked really hard to try and bring that price down. And it is still substantial, but that's the cost that we were told it's going to take to update CRISP in order to house the information that we would need to house and the information that would be collected under this bill. To Delegate Peña-Melnick's point, or Vice Chair Peña-Melnick's point, we will be following up with the health department and continuing these discussions and try to figure out if there's even more substantial ways to reduce that fiscal note.
Follow up, Madam Chair.
Absolutely.
Thank you. Delegate Belcastro, I can understand the $300,000 in the first year. It's the fact that it remains the same for 3 or 4 years that it's predicted that seems to me puzzling. I understand that when you do something new, it costs some startup money. So maybe you could break it down into 2 parts.
Okay, that's a great question, and we will follow up with the health department on that.
Thank you.
Thank you.
We have Delegate Lewis Young. You may ask your question, followed by Delegate Bagnall.
Thank you, Madam Chair.
My pleasure.
I'm sure you're all aware that the National Suicide Hotline 988 will go into effect in July of this year. And in our state, there's a pretty large implementation effort being planned to do our 988 hotline. Have you had any conversations with that group? Because I could see some opportunities on the front end in terms of planning and staffing from a data effort, and on the back end, getting data from the Maryland 988 hotline. And in fact, that data that the hotline could generate might reduce the fiscal notes after year 1.
So you raise a really great point. And to that point, I will defer to those that serve on the Governor's Commission for Suicide to see if there has been any collaboration. Eileen, do you have any insight on that?
I can say that we have been talking with the folks who are implementing 988. You all have probably heard of GBRICS and Thrive, and a lot of money has come into the state about that. So we are going to work really, really closely with them. The piece about 988 is that that's where people are going to go when they're in crisis. And what we are really going to try to do is prevent those crises from actually occurring. So you can, there's the prevention, there's the intervention. 988 is the intervention. And then we also want to be doing post-suicide healing. We call it postvention. So yeah, they're critical, and they're going to be even more critical to our behavioral health system. Thank you for asking that.
Thank you.
Delegate Bagnall, followed by Delegate Riley.
Thank you, Madam Chair, and thank you to the bill sponsor for bringing this forward. Looking at the bill and the membership for the commission, I'm wondering if you will also be looking at data for why people lived as well as why they died. Suicides that were not completed, that did not result in death, to address. As you're reviewing that data, what were the factors that also prevented fatality in a suicide attempt?
Thank you very much for the question. I see Eileen smiling and shaking her head as you ask it, so I'm going to defer to her again. Thank you for the question.
Thank you for the question. Yeah, so this is a suicide fatality review committee, so we're only looking at suicides. However, I can tell you that in the Governor's Commission on Suicide Prevention, we're having very intense discussions with suicide attempt survivors about how to do exactly that. Because if you look at an inverted pyramid, you'll see at the top folks who have thought of suicide, maybe considered suicide, A little bit down is people who have made plans. And then there's the folks who attempt, and then there are the people who actually die by suicide. There are thousands more people who have attempted than who have died. And so the reasons, the hope they received and the reasons that they stay alive are critical, just as critical as it is to find out why people died. So it's all part of prevention. Thank you for that question.
Delegate Riley.
Thank you, Madam Chair, and
My
thank you
pleasure.
to the bill sponsor. It's a great bill. I totally agree with it. However, after listening to some of the testimony, and I know we do have, the governor's suicide prevention commissioner, some of them on this call today, it sounds like maybe we could save cost and it make more sense that if we just give this data to that commission. So that we're not duplicating and having two separate commissions. Now, I don't know if that would be too overwhelming. Maybe Eileen or, one of the other members, could address that. But it seems like you all are already in position. And if you had the data, you could already, do what this particular bill is requesting. But with the current commission, which may reduce cost, and you have all the other information. So instead of, two different groups trying to connect with each other, that this data should just go to the current commission and we could, figure out what we have to do, to prevent these suicides. And I too, I had a family member that committed suicide. So this is very dear to my heart. And I've been trying to, work at this angle, but in a different way. And that's just to try to encourage more psychologists, especially in our schools. So this is very important legislation, but we don't want to duplicate our efforts. I was just wondering by the members here on the commission, do you think that this would be something if we had this data and it actually went to your commission that we could come up with the same results? So thank you.
Thank you again for the question, and not to sidestep all the questions of the committee, but we do have members of the commission here and they are more qualified to answer the question. So I see Janelle and Eileen again shaking their heads as members that have worked closely with the commission. I'll defer to one of you.
So I can speak from my past experience and then pass it to Eileen.
You can only one witness can answer. So
I'm sorry.
It's okay. Those are the rules of the committee.
Janelle, I think you're well equipped to answer the question.
Thank you.
Yeah.
We've considered that when we were in the process of drafting the legislation for this review committee. I think where it gets tricky is that the Suicide Prevention Commission is already tasked with some significant asks, developing the biennial state suicide prevention plan, developing a list of postvention resources. And I would say that the current membership of the commission doesn't have the same makeup as the fatality review team. So the Office of the Chief Medical Examiner is not part of the commission. We don't have medical doctors or psychiatrists. Some people, by virtue of their careers, may be mental health professionals or have lived experience, but the purpose of the fatality review team was to convene people with various levels of expertise around suicide. And we were very intentional to ensure that the chair is a listed member for the fatality review team to make sure that these two groups are communicating with one another, as well as having a member and representative from the State Suicide Prevention Office to facilitate communication between all three of those entities. So I really see the fatality review team reviewing fatalities, identifying opportunities for intervention. They can pass that over to the commission, who can then write it into the plan and make recommendations for policy and practice.
Excellent answer. Thank you very much. Appreciate it. Thank you, Madam Chair.
And for the record, Ms. Zeller was nodding to everything you said, so she was in agreement. Great, you handled it beautifully. Are there any other questions for this bill? I don't see any. So seeing none, that concludes the bill hearing on House Bill 48. Thank you so much for being with us today, and thank you for taking the time to discuss such a difficult issue. Okay. Next, we have House Bill 96. Delegate Shetty, will you be so kind and present for us the public health, non-discrimination in access to anatomical gifts and organ transplantation financial status? Good afternoon.
Good afternoon. Thank you so much, Chair Pendergrass, Madam Vice Chair, and members of the esteemed Health and Government Operations Committee. Thank you for the opportunity to be here with you today to share testimony in support of HB 96, a bill that will prohibit the consideration of a patient's financial information in the determination of which patients are eligible to receive anatomical gifts and organ transplants here in the state of Maryland. HB 96 amends our existing state laws around the factors that might be used to determine eligibility for an organ transplant or to be put on the wait list here in the state. A few years ago, under the leadership of this committee, a now law sponsored by Delegate Hill prohibiting disability from being used as a factor in determining a patient's eligibility for an organ transplant was passed into law. Prohibiting disability from being used as a factor was the morally right thing to do. And I'm so grateful for this committee's leadership on this policy. Placement on the transplant list, as well as the determination of a match, should be made based on medical factors alone. Anything beyond medical factors should only be used to bolster the support systems in place for patients during and post-transplant, and not to disqualify them for life-saving care. The bill before you today adds one further protection, prohibiting the consideration of a patient's financial status and means to discriminate against them if they might otherwise benefit from placement on a transplant list or from receiving an anatomical gift. Here in Maryland, we are so incredibly fortunate to have two top-tier transplant centers that assist patients in need of adult kidney, liver, heart, lung, or pancreas transplants, as well as pediatric kidney, liver, and heart transplants. Patients come from literally all over the world to seek care at Johns Hopkins and UMMC. It is of the utmost importance that patients who seek care at these centers are not turned away from receiving an organ simply because they do not have liquid savings. For example, in the case of kidney patients, a significant majority of whom are patients of color, our federal government covers the costs of patients in end-stage renal disease through the federal ESRD program within Medicare. It is an incredibly unique program through which any patient, regardless of age, is provided Medicare coverage as long as they have stage 5 kidney disease. All of their health care is covered, including dialysis in perpetuity, or the cost of a transplant and 1 year post-transplant. However, after that 1 year, if the patient is under the age of 65, they are removed from Medicare and they must seek coverage through the private market or through Medicaid. Through conversations with numerous kidney patients across the country, I've learned that many transplant centers nationwide outright refuse to allow patients under the age of 65 who would otherwise be perfect candidates for transplant to be on an organ transplant list unless they have a set amount of liquid assets. Sometimes that could be over $10,000 saved to cover for their cost of care once they're removed from Medicare. Not only does this cost our healthcare system an extraordinary amount of money, but this practice also significantly worsens patient outcomes. Patients who are on dialysis have an average 7-year life expectancy once they begin, whereas a kidney transplant can extend a patient's life well over 20 years. Just as extending the prohibition of disability as a factor for the determination of whether a patient might receive a needed organ is the morally right thing to do, so too is prohibiting the consideration of financial means in that same assessment. Doing so will improve patient outcomes, lower costs, and ensure that all patients who might otherwise medically qualify for a transplant will be able to be considered for this incredibly valuable gift. I just want to make a quick note. I've been working very closely with our transplant hospitals on potential amendments to ensure that they would be able to implement this bill if it's passed. Once we have those drafted, we will send them to the committee for consideration. I've also spoken with payers who have shared that they are neutral because by law, they are currently required to cover whatever is medically necessary. Thank you for your consideration, and I respectfully request a favorable report of HB 96.
Thank you, Delegate Shetty, for presenting House Bill 96. I do not see anyone signed up to testify. Are there any questions for Delegate Shetty? I see Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Shetty. So you talked about the high cost of dialysis. Can you give us a picture of how likely a person who's on hemodialysis is to be able to be employed and have money and save up funds to pay for their care, and how likely it is that someone who receives a transplant will be able to be employed and save money and participate in, giving the financial support for their care?
Thank you, Delegate Hill. That's a really excellent question. So for those who might be unaware, dialysis is an incredibly time-consuming process. It requires patients often to go to outpatient facilities, sometimes for an entire day or half a day, many hours, multiple times a week. And that is very difficult to work around a traditional employment schedule. And so for those who require hemodialysis, unless they're receiving at-home dialysis and they're doing it like overnight, which is becoming a little bit more common, but still the vast majority of patients are receiving them at outpatient facilities, then they're very unlikely to be able to hold a traditional job. And so they're, as a result, they are not likely to be able to save in order to be able to have liquid assets set aside to then qualify for the transplant. So it becomes a cycle, really, and one that is particularly harmful to those patients and their outcomes. Thank you.
Thank you.
Delegate Lewis.
Thank you, Madam Chair. Thank you, Delegate Shetty, for bringing this bill. It's really interesting. I'm curious to know how many people in Maryland could benefit from this bill if it were to pass.
Yeah, thank you, Delegate, for that question. So unfortunately, this type of data is a little bit difficult to acquire because we could get info on the people who are currently on the list. But really what you're asking is a more important question, and it's that of who might qualify, but who's never even approached about this as an option because they are either assumed to not have adequate financial resources, which is a really big problem, or they would qualify medically, but are removed from a list potentially because of the lack of these resources. So that type of data is part of the reason that we need this bill, actually, to ensure that more patients who could qualify medically would be able to be on the list and potentially be eligible for life-saving care. And again, while I gave an example of kidney, we do many transplants here in this state. I think we were just highlighted for like a particularly an interesting one with like the first pig heart transplant, I think, or something. So we do a lot of really innovative things here in our transplant centers. But the determination of whether or not somebody could be eligible for that, if part of that includes an assessment of their assets, then I think we have a really big challenge here. But thank you for the great question. And if I'm able to find great data to better answer your question, I will follow up with you.
Thank you so much. Thank you, Madam Chair.
My pleasure. Are there any other questions for Delegate Shetty? Seeing none, thank you so much, Delegate Shetty, for your testimony, and please keep the committee informed of your progress. And this concludes the bill hearing on House Bill 96. Next, we have the last bill of the day, which is House Bill 129, Delegate Charkoudian. And the title of the bill is Behavioral Health Crisis Response Services and Public Safety Answering Points Modifications. We're supposed to have the following delegates from Judiciary: Delegate Shoemaker, Anderson, and Rachel Jones. And I know Mr. Medina is actually reminding and notifying the committee. So Delegate Shakurian, will you be so kind and present to us House Bill 129?
Yes, thank you, Madam Vice Chair.
Our pleasure.
Chair Pendergrass, Vice Chair Pena-Melnick, members of HGO, and also members of the judiciary who are here. It's a pleasure to join you today. For the record, Delegate Lori Charkoudian here speaking in favor of House Bill 129. I want to begin by thanking you for passing a really important bill last year, which expanded mobile crisis units, expanded funding for mobile crisis units, and really, for the most part, put mobile crisis units in Maryland in line with best practice standards from across the country. So we really looked at making sure that the units were connecting people to peer supports, to ongoing supports, that we're collecting data to make sure they were really being responsive and culturally competent, and all of these things that the bill last year did. But there's two things that we weren't able to get done last year. And so this bill really is bringing those two things back. And both of these things are in line with the best practice standards from across the country. And you're going to hear from experts in these areas in their testimony after I finish. The first one is related to 911 and public safety call centers. So as you know, there's a lot of work, and I'm thrilled about the effort that's being put into getting people to call 988 eventually. There's been a lot of work to get people to call 211, and then the supports that are there for suicide prevention. But the bottom line is that right now, the vast majority of people in the state call 911 when there's a crisis. And this includes when there is a family member of theirs, or when they themselves are in a mental health crisis, or when they're witnessing something which is a mental health crisis. And so if we really want our mobile crisis units to work, we have to ensure that the calls that go to 911 have the ability to dispatch the best available resources. Now, in different communities, there's different resources that are available. So in some communities, there is a mobile crisis unit that might be available 24/7, 7 days a week, and enough to respond. I don't think we have enough anywhere to respond to all the crises, but enough to respond. And so in that community, the way that this bill is written, the policy could be that the 911 system has the ability to dispatch and send the mobile crisis unit. However, there may be another community where that unit is only available some days of the week. And so the way that this bill is written is designed to be flexible, to maximize the likelihood that 911 is able to do dispatch in a way that gets mental health services to a person suffering from mental health crises within the context of the resources that that community has available. And we have Bill Freddy, who ran the Montgomery County 911 system for a number of years. He's retired now. He'll be speaking about that component in a moment. The second thing that this bill does is it requires that the design of the mobile crisis unit program is designed to minimize the interaction between law enforcement and someone in a mental health crisis. Now, this concept of minimizing the interaction between the law enforcement officer and someone in a mental health crisis is a standard national best practice. The vast majority of law enforcement will agree with that. They'll talk about that they did not that they are here to do law enforcement, and while they do their best in every situation that's out there, they're not social workers, and they believe that social workers and mental health professionals should be responding to mental health crises. But there are times when it is appropriate, depending on the safety risk, level of violence, whatever it might be, that an officer might be dispatched. I think that in last year's conversations, there was confusion about this section, that it somehow limited it so that there never could be an officer responding either with a mobile crisis unit or responding to a violent situation. And so I want to make it clear that the goal of this section is not to eliminate, but it is to require that there be thoughtful processes at the county level within the mobile crisis unit level, so that all of the decision points maximize the likelihood of a mental health professional responding to that crisis and minimize the likelihood of having a law enforcement person respond to that crisis. And so I think that this also was written very carefully and very precisely to make sure that it was flexible depending on the different resources that are available across the state. And I think you'll hear from some of the experts who are going to follow me about why it's crucial that we make this shift in order to save lives and in order to maximize the likelihood that people in mental health crises get the healthcare response that they need rather than ending up in the criminal justice system or ending up dead. And I thank you for your time and I look forward to the conversation.
Thank you for your testimony today, Delegate. Next, we have Mr. Dan Rabbit. Will you be so kind and get started? You have 2 minutes.
Thank you, Madam Vice Chair, and good afternoon, delegates. My name is Dan Rabbit. I'm a Policy Director for Behavioral Health System Baltimore, BHSB. We are the local behavioral health authority for Baltimore City. Thanks for the opportunity to testify. BHSB is in strong support of HB 129. We see this as a common sense measure that will help advance our state's efforts to reduce our reliance on law enforcement when responding to mental health crises, freeing them up to do the job they signed up for. Mental health crises happen, and they are unfortunately on the rise. It's important to have effective crisis services for Marylanders experiencing things like suicidal thoughts, and we had a lot of discussion about that just a moment ago, and other mental health crises. And law enforcement must play a role. They must be a strong partner in the system that responds to these types of serious mental health symptoms. This bill doesn't change that, but police dispatch is not needed for many mental health crises. We've seen this in other states who've made efforts to reduce police and crisis response, where police are only needed to be dispatched in 10% or less of crisis events. In Baltimore City, our crisis response system has a strong partnership with our police department, but they do not send police on every crisis call. And this is a direction that national guidelines are pointing to as well. Most importantly, if you speak to individuals who've experienced a suicidal or mental health crisis, they report that police involvement can be counterproductive. Well-trained and well-meaning police still have handcuffs and weapons. They can be intimidating. They can make the person in crisis feel like they did something wrong. At BHSB, we've asked communities of people who are living with mental illnesses or those living in underserved communities, and they do not associate law enforcement with healing and support that they need to get over a crisis situation and stabilize. We should listen to them. They asked for a mental health response for mental health challenges. And so that's what the state should be directing crisis response programs that are funded by the state to do. And that's what 911 systems should have in place in order to ensure that they have policies that can minimize that as well. So that's what this bill does, and we urge a favorable report.
Thank you very much for your testimony this afternoon. We appreciate it. Next, we have Mr. William Ferretti. Good afternoon, sir. You have 2 minutes.
Good afternoon. Thank you, Chair Pendergrass and Vice Chair Peña-Melnick and members of the committee for allowing me to testify today. My name is Bill Ferretti. I'm the retired director from Montgomery County 911 Center. I also served on the Commission to Advance Next Generation 911 across Maryland, first as a member of the committee, and then since my retirement, I've been on the committee as an advisor. I really appreciate the approach that this bill has taken and the conversations that I was able to have with Delegate Charkoudian about the bill from the 911 perspective. It is a balanced bill that is not overly prescriptive. It allows us to recognize that 911 centers have different resources available to them in different communities throughout the state. But I also want to add a couple of things that were in my written testimony that I want to expand upon. Realize people call 911 when it's an active crisis. A lot of those calls luckily go to 211 and eventually will go to 988. But when someone is in active crisis, that call goes to a 911 center. They're not calling the police department, they're calling 911. And our 911 centers in Maryland triage calls based on the chief complaint. And you have to factor in not only law enforcement, but also medical. There may be medical issues. So I think what this bill does is add a third response type agency to this, which is your mobile crisis teams. And by creating a policy that involves all three of these, that is transparent and open to the public has a much more realistic expectation about what type of responders are going to show up at their doorstep when they're calling about a mental health crisis. And I think that having that transparency and setting those expectations will help with the overall response. So, and I appreciate the opportunity to testify today. Thank you. I urge a favorable report.
Thank you for being with us today. We appreciate it. Next, we have Ms. Maura Cyphers. Good afternoon.
Good afternoon. Thank you again, Madam Vice Chair. Maura Cyphers here on behalf of NAMI Maryland and in strong support of House Bill 129. When a Marylander experiences a mental health crisis, law enforcement is much more likely to respond than a medical professional. And the reality is when law enforcement responds, people in crisis often end up in jails, on the street, or worse, they're harmed or killed during the encounter. This costly dynamic is taking a toll on human lives, it's taking a toll on our state's resources. And we know there's a mental health emergency. We must provide crisis care as the first line of response. Like Delegate Charkoudian mentioned, there are all sorts of collaborative models that will ensure local governments can find something that works for them. This bill will strengthen the existing behavioral health crisis response grant program and start to force this necessary change. Quick aside, I think thank you to this committee for increasing that funding to the program last year and to Delegate Rosenberg, I believe, for starting it. The second thing that this bill does is help pave the way toward 988 by simply determining how 911 call centers are handling crisis calls. We need to know what crisis response protocol looks like, where the gaps are, and more importantly, who's responding, because that makes all the difference in the world. Family members and individuals in crisis are making a gamble when they call 911. And no matter how many good law enforcement officers we train, our current approach has led to the criminalization of mental illness in Maryland and across the nation. 1 in 4 people with a serious mental illness are arrested during their lives. 2 in 5 adults in jail have a diagnosed mental illness. 7 in 10 youth in the juvenile justice system have mental illness. 2019, 1 in 4 people killed by police officers in America had a known mental illness. That's up from 2015 when it was 1 in 5. Well-designed crisis response system can be the difference between life or death for people experiencing a psychiatric emergency. For these reasons, NAMI Maryland asks for a favorable report on House Bill 129.
Thank you for your testimony today. Next is Ms. Ansika.
Thank you, Madam Chair, members of the committee. My name is Ann Seacott, and I'm here today on behalf of the Maryland affiliate of the National Council on Alcoholism and Drug Dependence. And we're in strong support of House Bill 129. And we thank Delegate Charkoudian for introducing the bill. Increasing the number of behavioral health crisis services, including walk-in crisis centers and 24-hour mobile crisis teams, is necessary. We're moving in that direction, and that's great. Maryland's grant program allows these kinds of services to be used when people are experiencing a mental health or a substance use crisis. This bill strives to reduce the presence of police in responding to situations where they are not absolutely needed. The failed war on drugs has created a great deal of mistrust of police among various communities, including people who use drugs. The state has recognized this and in several ways has tried to address it, including in 2014, passing a Good Samaritan law to protect people from criminal charges when they call for help and someone's overdosing or experiencing another type of substance emergency. You've also passed legislation to decriminalize paraphernalia in order to reduce interactions between police and people who are in syringe service programs and outreach workers who are trying to distribute sterile supplies to people to minimize the public health impact of drug use. We hope this movement toward a more public health informed approach will also help Maryland, help lead Maryland in the near future to following the examples of Rhode Island and New York City in authorizing overdose prevention sites in order to save lives. Police are needed in many, many situations, but not in all. We support Maryland's movement toward better utilizing all of our limited resources. Thank you. We urge your support for the bill.
Thank you for your testimony. We appreciate it. And now we have a favorable with amendment witness, and that is Mr. Nibber from the Maryland Association of Counties. Good afternoon, sir. You have 2 minutes.
Thank you, Madam Vice Chair, Madam Chair, and members of the committee. My name is DePaul Nibber. I'm here on behalf of the Maryland Association of Counties in support of HB 129 with amendment. County law enforcement are often involved with mental health crisis response, as you've heard today. We detail a couple of situations where this happens fairly regularly. In short, law enforcement may be needed after hours, when other agencies are overextended or short-staffed, and to ensure the safety of crisis response workers. To be clear, we agree with those who have testified. A mental health crisis necessitates a measured response with trained professionals capable of de-escalation and the appropriate resources on hand. For the most part, we have no objections to this bill. In fact, endorse them wholesale. Understanding that law enforcement could play a role in this response, we have offered an amendment in our written testimony. As opposed to requiring behavioral health crisis response grant program applicants to minimize law enforcement involvement, our amendment would require applicants to detail and appropriately manage said involvement. This language is slightly less prescriptive, and none of the other provisions of this bill would be affected. And this would hopefully the other provisions of this bill will help guide counties towards having professional crisis response workers attend to situations involving mental health crises. And our amendment would also give counties an opportunity to evaluate their current programs and figure out a better way to divert resources away from law enforcement in these particular situations. And for this reason, MACO urges a favorable with amendments report for HB 129. Thank you.
Thank you for being with us today. There are no further witnesses. So now, are there any questions for Delegate Charkoudian? I have first Delegate Sample Hughes, followed by Delegate Shalega.
Thank you, Madam Chair, and
My
thank
pleasure.
you, Delegate Charkoudian, for the bill. It's very, very important, as we know we need to move in this direction. My question is more administrative and just trying to understand the processing and training. And so this question is for Mr. Ferretti. With the dispatch officers being in training for so long and trying to get all the pieces that they need to do their job, adequately trained, is there, obviously there would be additional training to this, but is there another certification that's going to be required of these dispatch officers? And if so, is there a model that will be potentially working from to get them the proper resources that they need as well?
Thank you for the question. I don't think that you're talking about an entirely different training. There might be some modifications to the current protocols that are in place for medical and for law enforcement that are currently used across the state in order to triage a call. I don't see it as a whole separate nuance, if you will, because 911 really still isn't the primary location for mental health calls. 90% of those calls, hopefully, will be before the person is in active crisis and a danger to themselves, and will be going to mental health professionals at 201 and 988. But when that person is in active crisis and they've reached a point where they're a threat to others, that call is going to go to 911. And for instance, a suicide that involves a weapon is going to be, and where there's actual act that's been taken place, is going to be processed for medical reasons for medical call. But the first responders that are going to show up on scene first are going to be law enforcement to secure that scene, followed in by the EMS folks. That's an extreme example. I could see where, depending on the level of and response time for community mental health teams, that there are certain situations, those low frequency but high threat situations, where law enforcement will come in, followed by a mental health team on the scene.
Okay. Thank you.
Thank you, Delegate. Delegate Shalega, followed by Delegate Hill.
Thank you, Madam Chair. And
My
this
pleasure.
question, I guess, could be for whomever would like to answer it. So I'm a little concerned, these calls can be the most dangerous calls according to law enforcement. You just look at what happened last week in Harlem with Officer Rivera and Officer Mora, who were killed, sadly killed last week, responding to a mental health crisis call. So what training are you giving other folks that are going to be responding? I mean, is there a requirement in there? Because I am very concerned about who's responding to these calls and that they're not prepared to protect themselves and to protect the public with public safety. You know, unfortunately, there was a third police officer at the scene in Harlem last week that was able to stop this person who had a gun from killing other people. But I'd just be concerned if we're sending some mental health professionals in who aren't armed and aren't prepared to protect themselves and the public.
Can Mr. Rabbit take that call? Is that?
Yes, absolutely. One person that will work beautifully, Mr. Rabbit.
Sure. Thank you for the question, Delegate. I think it's important to remember that people living with mental illness are far more likely to be the victims of violence than the perpetrators. Even people who are in crisis, the vast majority of these situations are not threats to public safety and do not result in violent activity. But what this bill is asking to do is that grantees for the Behavioral Health Crisis Response Program, as well as 911 911 centers, have policies in place that seek to delineate when do you send police, when do you send a mental health crisis worker, when do you send both, and try to minimize the reliance on law enforcement for what are mental health problems. That's what this bill tries to do. And so, the situation you described in Harlem, I'm not familiar with it. It's definitely a tragedy. But there's a lot of other tragedies where the person experiencing the crisis suffers, is arrested, or worse because of the situation. So it's just a balancing act of balancing public safety with the safety and well-being of the person in crisis.
Well, but my question was, what training are you going to give to the mental health responders? That was my question was, this is a dangerous situation oftentimes. And, that should be, like you said, a balanced approach. So what can you tell us about, again, the training for responders in dangerous situations who are not, hopefully you have a great answer for how you're training them so that they're not in danger. And of course, the public isn't either.
Yeah, I mean, so mobile crisis teams are different from every jurisdiction. And so there's, the training modules and the different resources they have to lean on vary from place to place. There is extensive training on both how to engage with the person in crisis and when to call for backup or when to not enter situations. Like that is definitely a component. But exactly what sort of training is different from place to place.
Thank you. So I might suggest that along with your language to minimize law enforcement, you should include some parameters for fully training people who are responding that are not law enforcement. Thank you.
Thank you, Delegate. Next, we have Delegate Hill, followed by Delegate Bagnall, followed by Delegate Saab.
Thank you very much, Madam Chair, and thank you, Delegate Tarkoudian. Hopefully this will be a 4 goddess afternoon. So the question I have, I know this bill is really focusing on the PSAPs and the triaging and who you send. And what I want to ask is there room in this bill to potentially address the issue of when both law enforcement and mental health professionals are responding, who has command or who has priority? So we've seen cases where EMS has been coming to a scene and they've been told by law enforcement, this person needs ketamine. When really that's not the decision that law enforcement should be making about what medical or behavioral health intervention. And because in some cases, it seems that because law enforcement is the authority, that EMTs, at least in some states, felt obligated to follow through with the recommendation from law enforcement that, okay, you guys want ketamine, we'll give ketamine. So I'm asking, even though this is not focused on the site where the incident is occurring, but how it's dispatched, if there is opportunity to address that once when we triage you, does PSAP say, and this is who has command, or this who has the lead, versus everybody shows up and we're both supposed to be and we figure it out?
Thank you for that question. I think it's a really important one. And one of the things that may be helpful in answering several of these questions is just to highlight that this one sentence that this bill includes related to minimizing interactions is one of many, many things that are part of best practice standards for mobile crisis units, including a lot of the issues related to how they work with community partners, how they make referrals, the training, some stuff related to training and so on here. And the reason that I say that is because I think that what this is trying to do is establish conceptual best practice standards and still be flexible enough for the local needs. So folks have maybe heard of like the CAHOOTS program in Eugene, Oregon, where it's one of the most famous, where there's been the vast majority of interventions that have really kept things out of the criminal justice system, lay people, not police, responding years and years and years. Everyone has stayed safe. So that like we have those examples, but you might have a county in Maryland that can't pull off that, but they can pull off something else. And so what I guess that's a longer answer than I intended to give, but the short answer is, I think potentially this bill is trying to say, here's the broad goals of what the mobile crisis unit needs to accomplish, including minimizing the interaction. And then you design it with the resources you have in your community and so on. So I guess what I would say is maybe you and I can talk some more. There may be a way to include that in here. I'm not sure if it fits because I think it potentially depends on the local resources, and I am trying to leave it flexible to respond to local resources within the context of the best practices. But I'm happy to have a follow-up call with you if you think there's something in here that, if you think it could fit with that kind of approach that we have in the bill.
Thank you, and thank you for the bill. Thank you.
Sure, thanks.
I have Delegate Bagnall, followed by Delegate Saab.
Thank you, Madam Chair, and thank you to the bill sponsor. I'm actually going to follow on to Delegate Hill's thought processes. I know there was some tension last year, specifically because of the model in Anne Arundel County for our crisis intervention team, our mobile crisis modeled after the New York City model. And I think I know the answer to this, but defining minimizing in terms of grant eligibility, is that at the discretion of the department? Is it flexible enough that an existing mobile crisis model will not be rendered ineligible if law enforcement is a part and parcel to that model?
I think it's a really good question. So the goal is absolutely to create a thoughtful dialogue in every county to look at what is the role of law enforcement and how much is it front and center in our response, even when we have mobile crisis units. So that is absolutely the goal. Now, having said that, it doesn't say if you have a law enforcement role for mobile crisis units, you can't get the money, right? That's not what it says. And so the way that I imagine this is, if you have a mobile crisis unit plan where you send law enforcement and social workers, and the default approach, regardless of concerns about physical safety, is that law enforcement knocks on the door first, and then social workers come later, right? I'm simplifying it, but let's say that's the default approach. I would say you probably need to challenge that approach. I would say this does challenge that approach. Now, does that mean law enforcement can never knock on the door first, can never secure a scene first, no, it does not mean that. That's not what this does. It wouldn't eliminate any program that has some situations where law enforcement might have a role, but it would say, if your default is law enforcement is always going to be first in a mobile crisis unit, I would say probably that's going to need to change, and that is the intention. We know research shows us that when there's enough information that we know that law enforcement is not needed to stabilize that scene, bringing law enforcement to respond to that crisis is going to make things, it could make things worse. It could be traumatizing. It could lead to an arrest. It could lead to a killing. It could lead to harm, could lead to criminalization. And so we absolutely want to, and so this word minimize, we spend a lot of time thinking about what the right word is. And we picked that very purposefully because we didn't think eliminate was the right word. And we understand that situations are different across the state and the resources are different across the state. But the language actually is proposals that contain response standards that minimize law enforcement interaction for individuals in crisis. And I think most people would say, we all want to minimize interactions, law enforcement and people in crisis. And so, so the goal is to continue getting as much money to fund as many mobile crisis units as we possibly can across the state, because gosh, we need more money as we can get. And it is to challenge all of us to look at that design and say, does this design do everything it possibly can to make sure we're responding mental health crisis first to a mental health response first to a mental health crisis?
Thank you. And thank you for that thoughtful response.
Thank you. Next, we have Delegate Saab, followed by Delegate Johnson. Thank you so much for your patience.
Thank you, Madam Chairman. So who determines who gets sent to a situation? Is it the 911 operator, or he says, well, this call requires police presence, this call, in my opinion, or whoever that answered the phone's opinion, that the social worker can handle it?
So there's a number of different ways that this plays out, and it's different county by county. So the part of the reason that this bill requires the 911 system to establish clear protocol and policies for how they make that determination, and to publish it, is that it would answer that question for you. Because right now, I don't know, most of us don't know, and to some extent, it may be different depending on who's on the shift. Like, we don't have written protocols, at least they're not public, about how that's done. So part of the goal of this is to make that transparent, because I think that would give us all a position, both local policymakers as well as state policymakers, to think about, is that the right way to do it, and do we want to refine that? And then the second is county governments within the design of the mobile crisis unit is making the policies about how mobile crisis units can be dispatched, and then who within those units respond in what ways, and when law enforcement is brought in, and so on and so forth. So as a local government.
Right, and I'm a big fan of the the crisis and advantage team. I've actually been involved when people have reached out to me and they needed help, and I've called them, and I understand the extreme, how important they are, and I believe that they are underfunded, and we need to help them. I'm just concerned about the the liability from both ends. Liability from when something bad happens. Is the 911 operator liable, or is the county government liable for not sending the right, the right people? Because the CIT and the police officers that do go to these calls are actually have extremely high and special, training. And in a situation when there's mental illness or there's crisis, it can escalate and can go, any which way. And I'm not so sure about limiting them. I just, concerned about the liability aspect, but I still, my opinion, I think, because situation can change and it's very dangerous, that we need some of that, now whether they're dressed up in police uniform or not, but we need that support. But thank you for the bill, though. I really, appreciate you putting forward. I'm just not sure about the limiting part, but definitely supportive of the increasing funding for them. Thank you.
Thank you, Delegate. Delegate Johnson.
Thank you, Madam Chairman, and
My pleasure.
thank you, Delegate, for bringing this bill. Delegate Saab asked part of my question, and I guess the other part is in the bill. So the folks at the crisis centers, if they get the call, they will have protocols in place and be trained to determine if an officer should go or not. Is that correct?
Right. Well, so at this point in time, it's in different counties, that is either a publicly available policy or it's not. Some places it is, some places not. So this would make it publicly available. So we would be able to see who's making the decisions and based on what. That's part of what the 911 piece does. But then within the policies of mobile crisis units across the country, every mobile crisis unit that I'm aware of has policies about the role of and when officers are brought in. So mobile crisis units across the country that respond with just mental health professionals have policies and procedures and training on when they would call law enforcement to join them on a call. And mobile crisis units that respond with police officers have policies on when the police officers would come into the scene. I'm not sure if that answers your question. I'm sorry. Is that?
Yeah, it does. I mean, our outcome, what we're looking for is safe outcomes for everybody. So yeah, that will include the 988 when it comes online. They will also have protocols in place.
So 988 will have protocols in place. That's not part of this bill, although part of what this bill does is it sets up the systems that will then dovetail into the 988 responses. This will set up the systems that'll support 911 to triage with 988, and it'll also set up stronger mobile crisis units, which can then be dispatched from the 988 system once that's in place.
All right, thank you. Thank you, Madam Chairman.
My pleasure. Are there any other questions for Delegate Cherkoudian and her panel? Okay, seeing none, this concludes the bill hearing on House Bill 129. Thank you and it also concludes the bill hearings for today. Thank you so much for your patience, and we hope you have a blessed evening. Thank you. Bye-bye.